Good
Yes,
evening.
so we are online, sir.
Yeah. Good evening, friends, delegates and participants. Thank you for joining Shield Connect. And today we are back with our series Icons in Conversation with Dr. Ritu. And today's topic is ovarian torsion. And today icon for the day is Dr. Ayman Sheata Dawood. Sir is Assistant Professor of Obstetric and Gynecology from Tanta University, Egypt. And our sponsor with Shield Connect, Dr. Ritu Santwani ma'am has launched this series. So let me give a brief introduction. Dr. Ritu Santwani ma'am is an obstetric and gynecologist, sexologist, cosmetologist and infertility specialist, founder and CEO of 360 Healthcare Studio, director of Shamwell Women Clinic and PTBC in Pune. And ma'am is also co-founder of MAAM and board member of WSCG. And now let welcome our icon for the day, Dr. Ayman Sheata Dawood. Sir has done MBBS, DGO, MS in obstetric and gynecology, diploma in ART and reproductive medicine from KIL, Germany. Sir has also done special training in fertility and IVF from Singapore and Chennai. Special training in cosmetic gynecology from Delhi, laparoscopic and hysteroscopic surgeon. Sir is consultant gynecology and infertility specialist and assistant professor of obstetric and gynecology from Tanta University, Egypt. Sir has published more than 86 publications on various interesting topics like nanotechnology in obstetric and gynecology, conservative management of placenta accretive, poor responders in IVF ICSI cycles, and more. So today, sir will take the session on ovarian torsion, and we are glad to have you, sir, on our platform, and Dr. Ritu ma'am for making this webinar possible. Thank you, everyone. Thank you, ma'am.
Yeah.
Thank you very much.
Thank you, Nishant. So a very, very warm welcome to all of my dear friends who have joined all across the geography, and a special, very, very warm welcome to my very dear friend, Dr. Ayman Dawood. Dr. Ayman has done one more session with me in this series only, that how to deal PCOS. That was very much highly appreciated by all. So in spite of his busy schedule, when I requested Dr. Ayman, our dear friend, that we need one more lecture from your side. So he, in spite of his busy schedule, he told me, no, yes, I will definitely come for the lecture. So Dr. Ayman, we are very, very much thankful to you for your sharing your knowledge with us. So friends, today's topic is very, very important, ovarian torsion. As you all know, we are getting so many patients in these days with the ovarian torsion, not only the adolescent girls, especially those who are practicing the ART infertility. We are having a lot of patients of ovarian torsion. So now how to deal these patients? So, recently, when I was going through the papers, recently the data has come. Only 2 days back, I have read this, that the role of sildenafil, the drug which has been used for this, for the male in sexual dysfunction, now is having a role for the treatment of the ovarian torsion also. So, like that, there are so many insights for the treatment of the ovarian torsion. So we are going to listen from our dear friend, Dr. Ayman, and later on we can have some question answers. And before that, switching the session to Dr. Ayman, I once again like to welcome all of my dear friends who have joined all across the geography. I'm able to see so many of friends have joined. So a very, very warm welcome to all of you. And the program is going live on the YouTube. So now once again, a very warm welcome, Dr. Ayman. The floor is all yours.
Thank you very much, Dr. Ritu, for your invitation. And I am very happy to join you. It's my pleasure to be the second time to be with you in a lecture. And all the time, I am ready to share with you any information or any lecture. It's my pleasure. Today, let me start. I will share the presentation. The slides are seen?
Yes, yes.
Yes, yes. So let's start. Today, I will speak about ovarian torsion. As Dr. Ritu said, it is very important torsion for everyone working in infertility. And every day we face this problem and we are in a dilemma how to manage. Is the management is one word, the torsion only? No, it is not only the torsion. As we follow the lecture, we will see how to manage the case of ovarian torsion. So please be attention, and any question we will answer at the end of the lecture. Again, I am Dr. Ayman Shahata from Egypt, from Tanta University, and this is where Tanta is located in the center of Delta of Nile. This is the Tanta University in Tanta, and this is Tanta University Hospital where we work in Egypt. Ovarian torsion, as you see this picture, there is a lot of coils of the ovarian pedicles, as you see. And when you look to this picture, you see that there is coil and there is also a lesion. So any torsion should be associated with a cause or lesion. This is another picture of ovarian torsion. As you see also, coils of the pedicle, and there is also a lesion. Ovarian torsion is the fifth most common gynecological emergency, accounting for 3% of emergencies following ectopic pregnancy, the first one, abortion, acute PID, and ruptured ovarian cyst. Ovarian torsion cause local ischemia and reduce follicular activity. And if we neglect this condition, it may lead to a loss of the ovary and finally infertility. Delayed diagnosis and the treatment can increase the risk of complication and may result in additional surgeries. Are you following? It can occur at any age, productive years, and the median age reported was 28 years. Are you following me? The voice is clear, please.
Yes, sir. We can hear you clearly.
The percentage of patients younger than 30 years is approximately 700 to 75%. This is a great percentage that when we see that most patients of ovarian torsion are younger age. So when we neglect this condition without diagnosis, most of these patients will lose their fertility. And when we see the videos later on, we will see that some patients have only one ovary, and this ovary is also distorted. And when we neglect this patient, it will lose its fertility forever. Two groups of women show particular tendency to be affected by adnexal torsion. The first group is women in their mid-20s and women who are post-menopausal. Adolescents also are at risk due to changes in the weight of maturing adnexal. Approximately 17% of the premenarchal, and this may enhance the suspicion of congenital factors. So when we face ovarian torsion in a premenarchal girl, we should suspect congenital anomalies or congenital factors. Although ovarian torsion in very young children is rare, but cases of ovarian cyst torsion reported in a 2-year-old infant. So the ovarian torsion occurs mainly in young age. What is the etiology of ovarian torsion? When we look at this slide, ovarian torsion has two main items. The first one is anatomically changed, affecting the weight or the size of the ovary, and the second is the position of fallopian tube also, and twisting occur. As you saw, any anatomically change affecting the weight or the size or the position of fallopian tube and ovary, this leads to twisting. So when we consider the etiology, first congenital factors. The second is pregnancy. The third is adnexal mass. And the third is pelvic surgery. And lastly, trauma. When we look at this congenital factors, what are the congenital factors that may predispose to torsion in young children? Elongated fallopian tubes, and this occur in premenarche or prepubertal patients. Long ovarian ligaments or absent mesosalpinx, and history of previous ovarian torsion. These can lead to torsion mainly in young premenarche or prepubertal patients. Pregnancy, ovarian torsion in pregnancy occur approximately in 20% of cases, and torsion occur mainly in the gestational age between 6 and 14 weeks. And torsion is due to ovarian enlargement due to presence of corpus luteum in combination with laxity of the supporting tissue. Why is the supporting tissue are lax in pregnancy? This is because high progesterone level, which leads to laxity of our ligament. The second etiology is, or the third one, is adnexal mass. One of these masses, PCO, as we know, polycystic ovary is enlarged. Ovarian cyst, if it is larger than 5 centimeters, or para-ovarian cyst, as you see in the picture, this is the ovary, and this is the para-ovarian cyst evident besides the ovary. All these lesions can lead to torsion. Also, one of the commonest lesions that cause ovarian torsion, benign and malignant ovarian tumor, and this occurs in 50 to 60% of cases. And the most common cyst or the most common tumor is the dermoid tumor, as you see here. And this is also one of the cases I met. This large mass was present in a case of ovarian torsion. Malignant tumors are less likely to result in torsion than benign tumors. This is because the cancerous adhesion and malignant infiltration will fix the ovary to the surrounding tissue. So there is no mobility or excessive mobility, and this leads to no torsion in malignant tumors. Ovarian hyperstimulation occurs with us in many cases of ovulation induction. When we induce ovulation induction in patients, some patients may suffer from ovarian hyperstimulation, and this leads to torsion of the ovary, and but also one of the common causes of ovarian torsion. Induction of ovulation due to numerous fecal lutein cysts that significantly expand the ovarian follicle. The last one of the fifth cause is pelvic surgery. Increase the risk of torsion because adhesion will provide a site around which the ovarian pedicle may twist. And the commonest surgery that causes ovarian torsion is tubal sterilization. So when we look to adhesion by name, we see that adhesion leads to torsion, and torsion can lead to adhesion, and this is a vicious circle. What is the pathogenesis of ovarian torsion? Torsion occurs due to two main mechanisms. First, hypermobility of the ovary, occurs in 50%, and adnexal mass is present in more than 80% of cases. So these are the two main mechanisms, hypermobility of the ovary and adnexal mass. When we look to the pathogenesis, firstly, there is ovarian torsion, and ovarian torsion leads to lymphatic obstruction. So this is the first one to appear, lymphatic obstruction, and this is one of the causes of enlarged ovary and are the main cause of black coloration of the ovary. After that, this leads to decreased venous return from the ovary, and later on, ovarian edema and internal hemorrhage. And later on, when the condition progresses, absent venous return, and later on, when the condition progresses, leads to absent arterial flow, and finally, ovarian infarction. And this is the pathological sequelae of ovarian torsion. Ovarian torsion may occur unilaterally in pathologically enlarged ovary, and torsion involves the ovary alone and may also affect the ovary and fallopian tube. And in this condition, we we say on this condition adnexal torsion, and about 60% of cases of torsion occur on the right side. Duration of ischemia causing ovarian necrosis is not yet known. And what is the clinical picture these cases present with? Firstly, we will start by symptoms. The most common symptom, which is present in 90% of cases, is a sudden pain in the lower abdomen. The second most common is adnexal mass. As I say, you should search for the cause of torsion. You should search for the cause of torsion. Nausea and vomiting present in 70% of cases. Peritoneal signs, which is tenderness and GERD, present in about 30% of cases. Fever may present in 2 to 20%, and abnormal genital bleeding may occur in 4% of cases. Pain is one of the most common presentation, which is present in 90% of cases. It may be sudden onset, progressive, or intermittent course. What about its nature? May be sharp, stabbing, or cramping. It is located in the lower abdomen, mainly unilateral, and may occur in bilateral in 25% of cases. It may be severe in minority of cases, and in minority may be mild pain. May follow exercise or vigorous activity, and may radiate to the back, pelvis, or the throat. Symptoms may be intermittent for several weeks, and this can occur if the ovary is partially torn. What about the signs of ovarian torsion? This is typically non-specific, and highly variable signs and symptoms may be present. And in most cases, you will find unilateral adnexal mass. Unilateral adnexal mass in 95% of cases, and there is tenderness on palpation, and this tenderness usually mild and found only in 30% of patients. However, the absence of such findings does not exclude the diagnosis of torsion. As we say to our students, think ectopic. Also, we say think of ovarian torsion, because it is an emergency, and when it is neglected, it will lead to loss of the ovary and loss of fertility if the patient have only one ovary. The non-specific clinical picture commonly results in delay in diagnosis and delay in surgical management. What are the complications of ovarian torsion? Complications torsion may include infection, and this infection leads to adhesion, also peritonitis, and this is one of the complications is responsible for the peritoneal signs. Sepsis may occur, also adhesions, as we will see in the next video. Chronic pelvic pain occur complication of torsion, complete avulsion and necrosis of the ovary, and infertility, although rare because the presence of two ovaries, but if the patient have one ovary, it will lose her fertility forever. When we look to this video, this is a case of previous to cesarean section, and there is ovarian torsion. This is the black color of the ovary, and one of the complications of the torsion is adhesion. As you see, this is the ovary, and this is the loop, bowel loops. Bowel loops are adherent to the torted ovary. As you see here, we are dissecting intestine or intestinal loops from the torted ovary. As you see here, this adhesion occurs in most cases of ovarian torsion due to chemical peritonitis and lymphatic obstruction. And as you see, this is the ovarian torsion adhesion. How can, this is an important issue, how to diagnose ovarian torsion. These are the 5 main parameters mentioned in diagnosis of ovarian torsion. Firstly, clinical suspicion. Good clinician should suspect ovarian torsion and should think in ovarian torsion. The second item is ultrasound, and this is an important modality for diagnosis. Doppler also is very important. CT MRI, we will report on its importance. And finally, the surgical diagnosis. Is my sound clear?
Yes.
Is my sound clear?
Yes,
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 sir.
clear, doctor.
Yes, thank you. Diagnosis clinically, you should suspect torsion when you, based on the symptoms and the result of your physical examination. When you find a young girl or young child complaining of lower abdominal pain and there is adnexal mass, you must suspect ovarian torsion. So clinical suspicion is very important. The next item is ultrasound, and this is the first modality for diagnosis. It is present in all our clinics. Color Doppler ultrasound is a method of choice for evaluation of adnexal torsion, as we will see now. CT and MRI are secondary modalities. When sonographic findings are not conclusive. The surgical diagnosis, when you open the abdomen or do exploratory surgery or laparoscopy, you will find there is coiling of the adnexa or coiling of the ovary, as we will see in videos later. The ultrasound signs are very important to know. There is, firstly, you will find unilateral enlarged ovary. Unilateral enlarged ovary more than 5 centimeters. And typically, it is located in the middle line above the uterus. Or located in the middle line or above the uterus. When you see this sign, you should suspect ovarian torsion. Coexistent ovarian mass, as I say, you should search for the cause. The third item in ultrasound is the variable echogenicity. Areas of hypoechoic and areas of hyperechoic, as we will see now. Ovarian tenderness on transducer pressure. When you press by the transducer, you will find ovarian tenderness. And ovarian edema and the free fluid is present in 80% of cases. And there is specific signs for ovarian torsion. The first one is whirlpool sign, or what we call it target sign. The second is the snail shell sign and string of pearl sign, follicular ring sign, as we will see now. When we look for this picture, this is the uterus, and there is an intrauterine device is present in the uterus. As are you seeing this picture? This is the uterus. This is the uterus, and this is the ovary. So this is not bladder. This is not urinary bladder. This is the ovary. This is the ovary. So the ovary here. The ovary here is present in the middle line. The ovary is present in the middle line, and this is not the bladder, it is the ovary. When we look at this picture, you must suspect ovarian torsion. The picture shows ovarian edema, and the ovary is enlarged, and this is a lymphatic obstruction filling the ovarian stroma, and this leads to ovarian edema and the free fluid, as you see here. This is the free fluid. This is the whirlpool sign due to coiling of adnexa, and the twisted vascular pedicle. This is the whirlpool sign. Snail shell sign is another sign of adnexal torsion. When you see it, you should suspect ovarian torsion. String of pearls is the sign like of PCO. As we see, it is a necklace appearance. Also, a string of pearl sign may occur in ovarian torsion. Follicular ring sign, as you see, this is collected fluid inside or collected lymphatic fluid inside the ovary, leads to hypoechoic rings around the antral follicle, and this sign is the earliest sign of ovarian torsion when we are still in the stage of lymphatic obstruction. What about the Doppler? As we know, the Doppler is one of the sensitive and specific factors, specific modalities for diagnosis of ovarian torsion. When we see absent ovarian venous flow, it is a common, and sensitivity is about 90% in the diagnosis. Absent arterial flow is when we see the sign, it is a sign of poor prognosis, and absent or reversible diastolic flow, and in some cases we find normal vascularity. So normal vascularity does not rule out torsion. You should return to your suspicion or your clinical sense. When you look at this picture on the left side, on the right side, this is normal vascularity of the ovary, and here there's absent vascularity in torsion ovary. Also, this picture shows no color flow at all. When you put the color Doppler in late cases, you will not find any color flow in these cases, and this leads to hemorrhagic necrosis and complete infarction of the ovary. What are the limitations of ultrasound? Presence of flow does not rule out torsion. As I say, normal vascularity does not rule out torsion, and you should put torsion on your mind all the time when you face such a case complaining of lower abdominal pain, longer midline ovary, you should suspect ovarian torsion. Also, venous thrombosis from torsion may occur earlier than arterial, causing emergency of symptoms without with presence of flow. So when you make ovarian Doppler, you will see that there is normal arterial flow, and this will deceive you in your diagnosis. So this is one of the limitations. The second limitation is the dual ovarian blood supply. Dual ovarian blood supply, as the ovary is supplied from the uterine artery and stenosis and from the ovarian artery. Intermittent torsion, when you face, this is one of the problems facing ultrasound, and also the lack of confining ovarian capsule are the limitation of ultrasound in diagnosis. What about CT? CT is one of the good modalities when the ultrasound is not conclusive. What are the CT will add? It will show the underlying lesion and also show the surrounding edema and friction. And hemorrhagic necrosis in non-contrast CT is suspected if the housing field units is more than 50. MRI, it is not the imaging modality of choice if torsion is suspected, and we don't request or rely on MRI at all. These are a combination of symptoms and signs. And this is one of the suspected algorithms. When you combine 5 signs, you will reach to 100% diagnosis or 100% suspicion. Edema of the ovary, absent abnormal flow, enlarged ovary, free fluid, ovarian cyst or mass. When you find these 5 lesions, you should suspect that you have ovarian torsion by 100%. Also, another 5 signs: edema, abnormal flow, free fluid, ovarian cyst, abnormal location of the ovary. As I say, midline ovarian location leads to 100 suspicion of ovarian torsion. But as you know, 5 signs and symptoms are too much. When we reduce these signs to 4 only: edema, abnormal flow, free fluid, ovarian mass. When you combine these 4 signs, you will reach to 100% diagnosis. Another 4: abnormal flow, enlargement of ovary, free fluid, ovarian mass, or abnormal flow, enlargement, free fluid, abnormal location. When you combine these 4 signs, also you will reach to 100% diagnosis. But also 4 signs are too much. We will reduce it to 3 signs to reach also 100% diagnosis: edema of the ovary, abnormal flow, abnormal location. When you find these 3 signs, suspect ovarian torsion by 100%. Also, abnormal flow, free fluid, or ovarian mass, suspect ovarian torsion. But also 3 signs are too more. We will reduce into 2 signs only to reach to final diagnosis: abnormal flow, abnormal location. So when you find these 2 signs, abnormal flow and abnormal location, suspect ovarian torsion and will lead to a 100% diagnosis. What about the ultrasound societies classifying ovarian torsion? International Society of Ultrasound in Obstetrics and Gynecology in 2009 classified ovarian torsion into 3 classes according to the venous flow, arterial flow, and its prognosis. They classified them ovarian torsion into 3 classes. The first class, the venous flow is present, arterial flow is present, and prognosis is good. And this is an early stage, and this is the stage of lymphatic obstruction. The second class, venous flow is present, arterial flow is absent, and this is intermediate prognosis. The third is absent, both venous and arterial, and this leads to poor prognosis, and finally ovarian necrosis. Also, one of the important issues is the composite index. Composite index is including these items. Nausea, if it is present, the score is 0. If the score is 2, is absent, is the score is 0. Duration of pain, it's more than 48 hours, it takes 0 score, and if it is less than 48 hours, it takes 2. And this is items of the composite index, which include nausea, duration of pain, ovarian volume, and ovarian ratio, which is the affected volume over the unaffected volume. And all it is scored as you see. And when the score is more than or equal to 5, it has 100% specific for diagnosis of ovarian torsion. So it is the composite index for diagnosing ovarian torsion. Let's look for the differential diagnosis in cases of ovarian torsion. It may be misdiagnosed with appendicitis, and this is the most common. And the most important one is the benign teratoma. So appendicitis is the most common, and most of cases are diagnosed as appendicitis and open for surgical interference for appendicitis. And finally, there is a surgical diagnosis. It is ovarian torsion, not appendicitis. So this is the most common one that enter in differential diagnosis of ovarian torsion. And the most common case is benign teratoma. Benign teratoma or adenoid cyst. UTI in females, nephrolithiasis, diverticulitis, pregnancy, endometriosis, intestinal obstruction, all can be a differential diagnosis for a case of ovarian torsion. And this is the important station, is the station of management, how we can manage a case of ovarian torsion. How we can approach the case. Did we will do laparoscopy or laparoscopy? Let's look to the evidence. The evidence recommendation when you suspect by history and physical examination that a case of ovarian torsion is present, the evidence say to gynecologic consultation and laparoscopy. And subsequent laparoscopy. As of all, laparoscopy is minimally invasive, and the case will not suffer from any complication of surgery. So the evidence support laparoscopic intervention for cases of ovarian torsion. What are the surgical interventions we will do? The first is detorsion of adnexa with or without cystectomy. So we can just do detorsion and later with or without cystectomy. The second is salpingo-oophorectomy. If there is complete, in certain situations, we will say how to proceed for salpingo-oophorectomy. The third item is detorsion and fixation of the ovary and prevention of recurrence, how to prevent recurrence of ovarian torsion, and management of torsion during the pregnancy, and management of torsion in adults. Let's start by detorsion of adnexa with or without cystectomy. As you see, detorsion with or without cystectomy, despite the necrotic appearance of the ovary, is acceptable treatment and evidence-based medicine recommendation. And they say also that ovarian function following the detorsion, even in cases of blue-black ovary, has been consistently documented with color flow Doppler later on. So when you face a case of black or blue ovary due to detorsion, and the ovarian function will be returned later on. When we look to this video, one of the cases of ovarian torsion, you see in this torsion the ovary is black, and when we detort it, the color becomes more to the right, to the red side, and we will remove the lesion. As you see here, we will remove an ovarian cyst in this ovary. And when you look to the case, the color of the ovary changed completely. The color of the ovary changed completely. It was black at the start of surgery, and now the ovary becomes normal. And in this case, we do fixation of the ovary to the peritoneum or to the lateral pelvic floor to prevent the recurrence. Also, another case of paratubal or paratubal ovarian torsion. You see the ovary or para-ovarian. This mass is para-ovarian cyst or paratubal cyst. Also, one of the adnexal lesions that was ovarian torsion. It was large, and we do evacuation of the cyst at first, and then do a cystectomy for this case. And we didn't fix this case because the lesion was removed. As you see, we removed the cyst, and finally, this is the appearance after detorsion and cystectomy. After detorsion and cystectomy. So the evidence recommendation, if cystectomy is not performed at the time of detortion due to fear of trauma, do incision drainage of large cyst and ultrasound evaluation after 6 to 12 weeks. So this is the evidence. If cystectomy is not performed at the time of detortion due to fear of
ضعيف يمي والله.
Hello? Hello? Dr. Iman Muhammad, please mute your microphone. If cystectomy is not performed at the time of detortion due to fear of trauma, do incision drainage of large cyst and ultrasound re-evaluation after 6 to 12 weeks, and you will find that the ovarian lesion will be resolved. The theoretical risk of cerebral embolism is 4.2% after detortion and is not found and shouldn't preclude conservative management of the ovary. And this is an evidence grade B. When to do salpingo-oophorectomy? When to do salpingo-oophorectomy? In these conditions, when there is a postmenopausal torsion, why I leave the ovary? This case a postmenopause. So the ovarian preservation is not the case, or it's not important to preserve the ovary in this condition. Also, when the patient completed her family and there is a risk of recurrence of detorsion ovary. Also, when the ovary is completely necrotic and we can proceed for salpingo-oophorectomy. The last one, when you suspect malignancy. When you suspect malignancy, you should do oophorectomy or adnexectomy. Look at this condition or look at this video. This also a case of ovarian torsion. The ovary is present in the midline, as you see, and there is some adhesion, and the ovary is detorted. The ovary is freely mobile, and in this condition, we do salpingo-oophorectomy. This is one of the easiest operations. You just cautery the adnexa and cut, and this is the final appearance after adnexectomy of the large mass. It's a very easy operation to do, but the difficulty is to preserve the ovary and preserve fertility. Detortion and fixation. When to shift to fixation of the ovary? If the case is recurrent torsion. We had a case in Tanta University Hospitals, recurrence of detortion or recurrence of torsion after 4 weeks of the previous surgery. 4 weeks of previous surgery. And in this condition, we must fix the ovary. The second indication for fixation is absent contralateral ovary. We will see a video of one ovary in a young girl about 10 years old. Congenitally long ovarian ligament. This is one also of the indication to fix the ovary. Torsion without lesion. Torsion without lesion is evidence grade 3. When there is no lesion in the ovary and there is torsion, you should fix this patient because recurrence is very common. Also, when you will postpone cystectomy later on, when you postpone cystectomy, please fix the ovary because the pathology is present. You don't remove the lesion. So it is better to fix the ovary. Look at this picture. This is the girl I said to you. It is 10 years old girl. 10 years old girl. It was operated in the 1st of May. was operated by me in 1st of May. And when you see this is the ovary, and the blood, this dark color is the fallopian tube. My assistant was thinking that this black color is a blood clot, but it's not a blood clot. It is the end of fallopian tube or the fimbrial end of the tube. We try to retort the ovary. There was 3 coils or 4 coils of the ovary. We do 3 coils, and this is the last coil. We will do it, and the ovary will regain some of its activity. This is the 4th coil. We are trying to, the ovary is really mobile, slippery. Now we, so this is my assistant thinking that this is a blood clot, but it's not a blood clot. This is the end of fallopian tube. When you look to the fallopian tube, it regains its activity. Look to this video, look to this part. Where is the second ovary? This is absent. Where is the second ovary or the second adnexa or the left side? Not present. Not present. Again, we will look to this part. Again, we will look to this part. You should look for the second ovary. It is not present. This is a 10-year-old patient with unilateral adnexia only. So this ovary is precious for this girl. So it's not still not menstruating, and it has 1 ovary. We do fixation of this ovary to the round ligament, and as we'll see where to fix the ovary. Where to fix the ovary. This girl was 10 years old, and it get to me after 1 month of fixation. The lesion resolved completely, and there is no pain, and the patient returned to her childhood activity, playing with her fellows. It is very hazardous for this girl if we are delayed in diagnosis, because it has only 1 ovary, and it is 10 years old and not yet reached to puberty. So please think of ovarian torsion, especially in this age category, please. How to prevent recurrence of ovarian torsion? By ovarian fixation. Also, one of the maneuvers which is recommended is application of ovarian ligament. Also, we give COCs, but I have some objection for this item, because some girls are still not yet reached puberty. How I can give them COCs? I can give COCs when the patient is in childbearing period, but I have some objection to this item. This is the site where to fix the ovary. We can fix the ovary to the round ligament, as you see, and I operated the case by fixation to the round ligament. This is one of the sites. The second site, another site, is the ovarian round ligament also, and you can fix the ovary to the uterosacral ligament. Uterosacral ligament. There is a debate regarding whether the preventive use of ovariopexy should be taken in all cases or only in cases of recurrent torsion. This is still a debate. It is unknown what is the effect, if any, if fixation can affect future fertility, and whether they provoke significant anatomical disturbance or associated pain. This is still not evident about fixation of the ovary. This is the items of debate about ovarian fixation. This is the application of the ovarian ligament. As you see in the picture, it's a very long ovarian ligament, and application is one of the recommended steps for prevention of recurrence. Application is the preferred technique of ovariopexy and has minimal effect on fertility. And when we do combination of techniques such as application and fixation, will be more efficacious and in preventing recurrence. What about the management of torsion during pregnancy? When you face a case of torsion during pregnancy, firstly, detorsion of adnexia has no effect on fetal well-being. So, do detorsion and supplemental progesterone. If the corpus luteum cyst is removed during pregnancy, you must supplement progesterone. laparoscopy can be used for both confirmation of diagnosis and treatment, and management of torsion has the same technical difficulty due to the size of gravid uterus, has some technical difficulty due to the size of gravid uterus. The recurrence rate in pregnancy is high, about 90.5% in pregnant women and 9.1% in non-pregnant women. The management of adnexal torsion in adolescent. So look to this algorithm. When you are in pediatric or adolescent patient with acute pain or acute abdominal pain, do ultrasound. If the patient has enlarged heterogeneous ovary, asymmetric ovaries, multiple peripheral follicles, where Leboul sign, when you find these signs in pre-pubertal girl, do diagnostic laparoscopy. You will not lose anything if you find all are okay. So, but if you neglect the case, the patient will lose much, as the case I presented, which was 10 years old. Finding not suggestive adnexal torsion, normal ovary, symmetrical ovaries. When the pain persists, evaluate for other etiology. Or when the pain resolves, observe this patient, it may be a case of intermittent torsion. So some of the investigated drugs is the little-rich plasma injection. Also, as Dr. Ritu said, sildenafil, also one of the drugs investigated in the management of cases after detorsion. After you make detorsion, you can supply inject BRB in the ovary or give sildenafil to increase the vascularity of the detorted ovary. What are the post-ovary follow-up? You should do ultrasound 2 to 3 months to document ovarian function again. And you can do second local laparoscopy 2 to 3 months if you postpone cystectomy. If you postpone cystectomy for a second sitting. What are the prognosis in cases of ovarian torsion? Prognosis is excellent with early diagnosis and appropriate treatment. However, most cases have delayed diagnosis and often result in infarction and necrosis of the ovary. The ovarian salvage rate has been reported below 10% in adults and as high as 227% in a study among pediatric patients. Finally, this is the last slide. I am sorry for the long lecture. Ovarian torsion is considered an emergency and surgery required to correct it. Diagnosis of ovarian torsion continues to be a difficult task, requiring awareness and a high degree of suspicion. The most consistent finding is unilateral enlarged ovary plus absent blood flow and abnormal location, without which the diagnosis is unlikely to be ovarian torsion. Absence of ovarian Doppler flow is highly specific for torsion, but normal Doppler does not exclude torsion. Think of the cause, think of the etiology, ovarian mass, which cause torsion. Emergency laparoscopy is helpful in both diagnosis and treatment. Detorsion with or without cystectomy is the ideal management. Try to preserve the ovary regardless of its black color and consider orthorexy and adenexectomy in special situations as we mentioned in the lecture. And finally, thank you very much for your attention. Thank you.
Thank you, sir.
Thank you very much.
Okay, sir. Thank you so much for giving this detailed information regarding ovarian torsion. So, delegates, if you have any queries on this topic, you can please share your questions on chat box, so we can have a Q&A session with sir. Ritu, ma'am.
Thank you, Dr. Aman, for such an excellent lecture. I don't know, my laptop is hanging again and again. Now again, the camera is not getting on. So you have covered each and everything. A very, very excellent lecture with so many take-home messages. So friends, if any questions we can take now. No, at present, no questions. Are you able to see any questions in the chat box?
Okay, we received one
Ritu
question.
ma'am,
Yeah.
someone messaged me. I have posted in chat box.
Okay. Let me go through. Yeah. Dr. Aman, first of all, there is one comment from Dr. Jaya Bharti. Thank you for the very nice presentation.
Thank you very much.
Yeah. Another question is like, does AMH values get affected in the torsion of ovary?
Yes. This is one of the debate topic also, and this study is not conclusive in this item. And some cases of young children, how we can do AMH in this girl? The question is, AMH affected in the childbearing period? This is the question. Yes. Oh, it is still a debate if it is affected or not, and how we can measure AMH in young children. This is still a debate, and we will not reach to final conclusion. Studies didn't reach to final conclusion in this issue.
Yes, very true. That's why whenever the patient with the ovarian torsion, we all are very, very much careful so that the ovary shouldn't go on for the necrosis. That's why the treatment for the torsion as early as possible is very important. Yes, I'm totally agree with Dr. Ayman. Still, a lot of studies are going on for this AMH value.
Yes.
Yeah. So let me check if any more questions.
One feedback we received from Dr. Jaya Bharti.
Yes.
Thank you for the nice presentation.
So I think we can wind up if there are no more questions today.
Yes.
Net
Yes.
connection is also troubling a lot. Sometimes voice is not coming, sometimes camera is not able to hold. I don't know what is that.
Yeah.
Thank you very much, Dr. Ritu. And I am ready for any other questions.
At present, no more questions. The presentation was such a self-explanatory. Everybody is very happy with the presentation. So thank you once again.
Thank you.
Yeah.
Thank you very much. Thank you.
Yeah, bye. With this, we will wind up, friends, for today. So we will connect again on next Thursday. Same time, India time, 8:30 p.m. with another very important topic. Till then, bye-bye. Stay safe, stay healthy, and good night.
Good night.
Bye, everyone. Bye, sir. Good night.
Everyone.
Bye.